Hi everybody, and welcome to our module on the brachial plexus. The brachial plexus is a network or a web of nerves that derives from the spinal cord. It provides motor and sensory innervation to the arm, and when elements of the nerve plexus are damaged, this leads to classic nerve syndromes, and this is what they want you to know for step 1 of your board exams. Let me start by reviewing spinal nerve roots in general. There are 8 cervical spinal roots, 12 thoracic, 5 lumbar, and 5 sacral. Now the confusing part is there are only 7 cervical vertebrae, so how can there be 8 cervical spinal nerve roots? And to understand this, you need to understand the way these nerve roots are named. If we're looking at the cervical spine and we find the C1 vertebrae, the C1 nerve root is going to come off above the C1 vertebrae, and this is going to be the case all the way down until we reach C7, which is the last cervical vertebrae. At C7, we have nerve root C7 come off above that, but we also have nerve root C8 that comes off below that. This is just a peculiarity of the way these nerve roots are named. After this, we move into the thoracic spinal canal, so we've got the first thoracic vertebrae, and the T1 nerve root comes off below that. And then this is the case all the way down the rest of the spinal column. The vertebrae has the nerve root with the same name coming off below it. The only exceptions are up in the cervical spine. So now that we understand that, let's take a look at a drawing of the brachial plexus. So the brachial plexus derives from nerve root C5 all the way down to T1. And the plexus is basically a web of nerves like you see on the screen here, and it can be broken down into the roots, which come off the spinal column, and then trunks, and then divisions, and then cords. And all of these structures give off important nerves for the arm. For example, here's the axillary nerve, here's the radial nerve, and we'll go through all these things in the rest of this video. In the anatomy lab, you may have gone to great lengths to identify all the individual components of the brachial plexus. You don't need to know all that for step 1. You just need to know the brachial plexus lesions shown on the slide here. There are 5 nerves from the brachial plexus that often develop lesions. You should know those. There are 2 trunk lesions, and finally, the long thoracic nerve can have a lesion. Let's start by talking about the axillary nerve. If we go back to this drawing, this is the axillary nerve. It's an extension of the posterior cord. But notice the way it's drawn in this picture. It comes off sort of the top of the posterior cord. And if you remember that, it's an easy way to remember that most of the fibers for the axillary nerve come from C5 and C6. So even though the posterior cord receives fibers from C5 all the way down to T1, it's the C5 and C6 fibers that largely give rise to the axillary nerve. The axillary nerve is named for the axilla, or the armpit, and if you remember this, it's easy to remember that it innervates structures found near the armpit. One of the major structures found near the armpit is the deltoid muscle. This is a large shoulder muscle. It's the muscle that gets huge in bodybuilders, and it's responsible for much of the abduction at the shoulder. In particular, it's responsible for abduction from 15 to 90 degrees. So you can imagine that patients who have an axillary nerve lesion will have difficulty abducting the shoulder. In addition, the axillary nerve also provides sensation to the skin over the deltoid, so this skin will become numb in patients with an axillary nerve lesion. So ways that this nerve can be damaged involve processes that occur near the armpit. So a fracture of the proximal humerus right near the armpit can damage the axillary nerve. This can happen to an elderly patient who falls onto their shoulder. In addition, if patients have a dislocated shoulder from trauma, for example during a football game and a tackle, this can lead to anterior displacement of the humerus, meaning the humerus moves out of the joint and forward towards the front of the body. This can damage the axillary nerve and also cause weakness of abduction and loss of sensation over the deltoid. Moving on, now let's talk about the radial nerve. Going back to this picture, the radial nerve is shown here. Like the axillary nerve, it derives from the posterior cord, and the posterior cord receives some nerve fibers from all the levels of the brachial plexus, C5 to T1. Now in the case of the axillary nerve, we talked about how C5 and C6 were the main nerve roots for the axillary nerve, but in the case of the radial nerve, all the levels from C5 to T1 deliver some nerve fibers that supply the radial nerve. If we look at this picture on the right side of the screen, this is the radial nerve shown here. It wraps around the humerus and innervates muscles in the back of the forearm. The easy way to remember the muscles that are innervated by the radial nerve is to just think of the radial nerve as the major innervator of extensors in the arm, wrist, and fingers. So the radial nerve innervates the triceps, and that will extend the arm at the elbow. It also innervates extensor muscles in the forearm. So on the back of your forearm, you find many muscles that extend the wrist and fingers, and these are all innervated by the radial nerve. In addition, those muscles supinate the forearm, and so this motion requires the radial nerve. And then in addition, it's sensory to the skin at the back of the hand and forearm, and that should make sense if you remember that this nerve also innervates the muscles on the back of the forearm. A brief word on flexion and extension of the wrist. At the bottom of the screen is a flexed wrist on the left and an extended wrist on the right. There are a number of wrist flexor muscles, but two of the important ones are the flexor carpi radialis and the flexor carpi ulnaris. They are innervated by the median and ulnar nerves. In terms of major extensors, those are shown here on the right side of the slide, and they are all innervated by the radial nerve. What this means is when you lose your radial nerve, these flexors will dominate and the wrist will assume a position like what's shown on the left side of the screen. That's called wrist drop, and that's the hallmark of a radial nerve lesion because you lose the extensors and the wrist flexors dominate. So now let's talk about some of the clinical findings you could see in a radial nerve lesion. First of all, the triceps muscle may show weakness. This especially happens when the injury to the radial nerve is high up in the axillary area. Remember that the triceps extends at the elbow, so this is going to present as difficulty extending at the elbow. And then, as I told you on the last slide, wrist drop is a classic finding in a radial nerve lesion that's shown on the screen here. That's because of weakness of the wrist and finger extensors. And then finally, in a radial nerve lesion, you can see sensory loss to the back of the hand and forearm. The areas shown in red in this picture at the top right side of the screen here are all innervated by the radial nerve. Some causes of radial nerve lesions are shown on this slide. A fracture of the humerus, classically at the mid shaft, which is this portion right here, may cause a radial nerve palsy. Patients who are on crutches can compress the radial nerve where it runs in the upper arm. And then patients who sleep with their arms out over a chair, alcoholics sometimes do this if they pass out. These patients can develop a radial nerve palsy. This is sometimes called the Saturday night palsy. This can also happen if someone passes out with their head on their upper arm and compresses the nerve that way. Now, the lesions of the radial nerve are a little bit different depending on whether the nerve is injured up near the axilla or down closer to the elbow. And to understand this, you need to appreciate that the radial nerve runs adjacent to the humerus in something called the spiral or radial groove. It's also called the radial sulcus. It's found on the humerus bone, and the radial nerve runs there. And for this reason, the radial nerve is vulnerable to compression against the humerus bone in this location. If there is a radial nerve lesion at the level of the axilla, so that's very high up in the arm, this will lead to motor and sensory loss in all the areas supplied by the radial nerve. So there will be triceps muscle weakness, which will present as difficulty extending the arm at the elbow. There will be weakness of the wrist and finger extensors, and there will be sensory loss at the back of the hand and the back of the forearm. If the lesion is lower down, such as in the radial groove, however, the findings are different. In this situation, the triceps muscle is spared, but there will still be weakness of the wrist and finger extensors. In addition, this area shown in red is also usually unaffected. That's because it's supplied by branches that are given off before the radial groove. The only sensory findings are due to damage to the superficial branch of the radial nerve, which supplies the back of the hand right here. So patients who have a radial groove lesion have normal triceps muscle, in other words, normal extension at the elbow, and they do not have sensory loss at the back of the forearm. Moving on, our next nerve that derives from the brachial plexus is called the musculocutaneous nerve. This comes off the lateral cord of the brachial plexus, derived from nerve roots C5, C6, and C7. If we go back to this drawing, this is the musculocutaneous nerve shown here. It comes from the lateral cord, and the lateral cord receives innervation from C7, C6, and C5. This muscle innervates the biceps. That's the major muscle you should think of as associated with the musculocutaneous nerve. This is a picture of a man doing a biceps curl to remind you that the biceps flex at the elbow. The musculocutaneous is also sensory to the lateral forearm. If you look at this picture at the top right side of the screen, this area shown in brown is innervated by the musculocutaneous nerve. So if a nerve lesion of this nerve occurs, which is relatively rare, you will see weakness of elbow flexion and sensory loss to the lateral forearm. Going back to this slide, we've now talked about nerve lesions of the axillary, radial, and musculocutaneous nerves, and I'll talk about the median and ulnar nerves in the video on the hand because they're the major nerve supply to the hand. So now I'm going to talk about lesions to the trunks of the brachial plexus, and you can basically think of two trunk lesions. One is an upper lesion and one is a lower lesion. On this slide, you can see that there is an upper trunk of the brachial plexus formed by C5 and C6, and we'll talk about what happens when there's a lesion of that trunk. There's also a lower trunk here, which receives fibers from C8 and T1. A C5-C6 trunk lesion is also called an Erb's palsy or an upper plexus injury, and this type of brachial plexus injury is caused by excessive angle at the neck or shoulder where the brachial plexus originates. This stretches or tears the nerve roots, and that leads to nerve damage. And the classic cause of this type of trunk injury is birth trauma. Many babies experience what is known as shoulder dystocia. This means the shoulder impedes delivery through the vaginal canal. So when the baby is ultimately delivered, the baby may have stretching of the angle between the neck and the shoulder, and this can lead to an upper plexus injury. When there's injury to the upper trunk, this affects nerves that derive from the upper trunk. So this includes the axillary nerve, which, as we talked about before, innervates the deltoid muscle that you need for abduction. So a baby with an upper trunk injury will have the shoulder flat at the side with the upper arm pressed against the chest. In addition, the upper trunk supplies the musculocutaneous nerve, which, as we talked about before, innervates the biceps muscle that you need for flexion at the elbow. So because of this, the elbow will be straight in a baby with an upper trunk injury, and the forearm will be down at the side, just like the upper arm. And then finally, the upper trunk supplies the suprascapular nerve, which innervates the infraspinatus, which is important for external rotation. So the baby won't be able to externally rotate the arm, and therefore the arm will be internally rotated. So if you put all those lesions together, what you get is something like this picture shown on the screen here. The baby will have the arm straight down at the side. It will be straight at the elbow, and the baby can't abduct, so the upper arm is against the chest. And then the arm is internally rotated, meaning the hand is facing out or backwards. And this is sometimes called the waiter's tip because it looks like a waiter who is putting his hand behind him so that he can receive a tip. And if we go back to this picture, I just want to show you where all these nerves are. So this is the suprascapular nerve here. Down here we have the musculocutaneous and axillary nerve. They all derive from C5 and C6, and that's why all of these can be dysfunctional when you have an upper trunk injury. Next, let's talk about a C8 to T1 trunk injury. This is also called a Klumpke palsy or a lower plexus injury. This type of brachial plexus lesion is usually caused by excessive abduction of the arm. The classic way for this to happen is for someone to fall from a tree branch like this girl shown on the screen and then try to catch another tree branch to prevent themselves from falling. The arm is then yanked outwards and upwards. That's abduction, and that can cause a C8 to T1 trunk injury. You can also see this from birth trauma, but it's much more rare compared to an upper trunk injury. The major nerves that are affected by a lower plexus injury are the ulnar and median nerves, and this will impact the intrinsic hand muscles. In the video on the hand, I talk about this in more detail, but the intrinsic muscles of the hand are supplied by the ulnar and median nerves. Now, I told you earlier that the flexors at the wrist are supplied by the ulnar and median nerves, but they're usually not part of a lower plexus injury. That's because they are spared because they're innervated by different roots than the C8 to T1 roots that supply the lower trunk. I'll show you a picture of that in a second. So what you get in a lower plexus injury or a Klumpke palsy is the clawed hand shown in the picture here, and it is a complete clawed hand. In an ulnar or median nerve syndrome, you could have half of the hand affected to form a claw, but in a trunk injury, you have the entire hand forming a claw, as is shown. This happens because the MCP joints are hyperextended and the interphalangeal joints are flexed, and that's what gives you the claw hand. And in the video on the hand, I talk about why the hand assumes this position in nerve injuries in more detail. And I just want to show you here that the lower trunk, which is C8 and T1, supplies the median and ulnar nerves, and that's why they are the major nerves that are impacted. However, these nerves also derive some innervation from other roots, like through the lateral cord, and that's why you can see some muscles retain their innervation even when the lower plexus is injured. Now let's talk about the thoracic outlet syndrome. This syndrome occurs when there is compression of nerves and vessels as they leave the thorax. The place where this occurs is above the first rib and behind the clavicle. This section of the body is called the thoracic outlet. There's a picture of it on the screen here. So we've got a rib here at the bottom, we've got the clavicle right here, and between those two bones, we've got a number of nerves as well as arteries and veins, and if they become compressed, that can lead to the thoracic outlet syndrome. The anatomic location where these nerves and blood vessels become compressed is called the scalene triangle. This is a triangle formed by two muscles, the anterior and middle scalene, and above the first rib. If you look at this drawing on the screen here, we've got the first rib along the bottom running below the nerves and blood vessels. Then we've got the middle scalene here and the anterior scalene here, and this forms a triangle through which the nerves and blood vessels course. It's very high yield to know why some individuals are predisposed to the thoracic outlet syndrome compared to others, and one of the most common reasons for this is the presence of a cervical rib. This is an anomalous extra rib from the 7th cervical vertebrae. If you look at this drawing of the rib cage on the top right side of the screen here, normally the first rib comes off the first thoracic vertebrae, and there are no ribs above this level. However, some individuals are born with a rib coming off the 7th cervical vertebrae, and this predisposes to the thoracic outlet syndrome. This often occurs if someone who has a cervical rib suffers a hyperextension flexion injury. This is often called a whiplash injury. This can lead to development of the thoracic outlet syndrome by compressing those nerves and blood vessels. If you look at the bottom left side of the screen here, this is a 3D CT scan showing a cervical rib right here coming off the 7th cervical vertebrae. You can also see them in these x-rays here. I'm highlighting it in this x-ray in the middle of the screen here. There's also a cervical rib shown bilaterally in this x-ray on the right side of the screen here. Anytime someone is born with one of these ribs, they are at risk for the thoracic outlet syndrome if they have the right kind of injury. The clinical features of the thoracic outlet syndrome include injury to the brachial plexus. It's usually a lower plexus injury, so the patient presents with a Klumpski palsy and the claw hand like we talked about before, and the symptoms are often worse with elevation of the arms or hands because this compresses the nerve to a greater degree. In addition to the nerve injury, however, there will be symptoms related to vascular compression. So usually the thin-walled veins are compressed and this leads to a swollen arm. In addition, there can sometimes be arterial compression, although this is rare. This can lead to ischemia of the hand, where the hand is painful and pallorous and cool to the touch. There can be a lower systolic blood pressure in the affected arm, and the distal pulses can be weak. But the way to recognize this in a board question is that it will be a brachial plexus injury in addition to evidence of vascular compromise like arm swelling or ischemia of the limb. I'll finish with this slide on the long thoracic nerve. If we go back to this slide, this is the long thoracic nerve. It derives innervation from C5, C6, and C7, and you can see that it comes off very early in the brachial plexus before the development of trunks, divisions, and cords. The main thing to know about this nerve is that it innervates the serratus anterior muscle, which pulls the scapula against the rib cage. This is a picture of the serratus anterior shown in the bottom right side of the screen here. So if there's a lesion to this nerve, which sometimes happens from trauma, this will lead to winging of the scapula, where the scapula sticks out from the back. This is a picture of a winged scapula shown on the screen here. The way you usually demonstrate this clinically is to ask the patient to press their outstretched arm against the wall. When they do this, that will lead to the scapula protruding from the back, and that's the way you can uncover winging of the scapula in a long thoracic nerve lesion. And that concludes our video on the brachial plexus.